Welcome, everybody. Good evening, hello, good morning, good day. All over the world, we are greeting you today again from Berlin. It's Tuesday again, and we welcome everybody to the Quintessencial Tuesdays with Dr. Chris, featuring Dr. Otto Zur today, who is going to talk about a little different topic with the future in view, tooth preservations and implants in the course of the patient's life. A little housekeeping rule, please use the Q&A tool to ask your questions. Don't use the chat. We will not be able to answer questions from the chat. The chat is only for technical questions, whether you have no audio or something's wrong with the transmission, or you have a general question. But questions for the authors or Dr. Chris or Otto, please use the Q&A tool. Other than that, I'd like to welcome Chris, and I'm asking him to turn on his mic and his camera. Just say hello to everybody. Hey, Chris, I hope everything is well.
Nice. I am doing very well because it's an honor to have you here. What's up, Chris?
The last thing is that, of course, in Germany, it's Tuesday afternoon, so it's gin o'clock. I like your glass. Very nice. So for everybody joining us in the afternoon or in the evening, please enjoy a drink while you learn. It's just a little bit of, coming down after days of work. Chris, the stage is all yours. Thank you very much again for being with us today, and enjoy the next hour.
Thank you, Christian, and to welcome everybody to the Quintessencial Tuesday. It's a real honor for me to have Otto Zur, because in the year 2001, I started to work in his office for 3.5 years. And this completely changed my knowledge and my education in dentistry. And this was the completely life change for my dental living. I really enjoyed that time. And I have to say, most of my concepts are still based on what I learned in Otto's office. Otto is on stage one of the guys who have very high sophisticated cases. And also his lectures are very high sophisticated. Otto has one of the best-selling books Quintessence ever had. I only can recommend this to you. Read this book, then you learn a lot of periodontology, implant dentistry, and aesthetics. But today he told us that he wants to go a little bit back to basic, which I think is a very good idea, because we had so many webinars here where we only had high sophisticated cases. And I think it's always good to go a little bit back to the roots. And now, Otto, I'd like to welcome you. Christian, you have to start his camera, because without Otto, it's getting a little hard.
Working on it. There he is.
There he is. Otto, welcome. And I thank you very, very much that you can spend a little time with us together on this Tuesday. The stage is yours, and we are really excited what you will tell us in the next hour.
So Christian, thank you very much. Can you hear me? Is all good?
Perfect.
So I have to start my presentation, sorry.
Yes, please.
I know that. Here we Very good. Wait a moment.
See, even in Otto's library, pink is the dominant color.
And unfortunately, you have to wait a little more for book number 2. But he told us that he's on nearly at the ending. So perhaps this year we have a new pink colored book in our hands.
So do you have a picture? I'm sorry.
No, we have your picture.
Okay, good.
Bildschirmfreigabe hast du gemacht?
So, yeah.
Nee, ist noch nicht. Wir sehen nur dich momentan, Otto. Du müsstest die Bildschirmfreigabe machen und dann fragt er dich ja, was du freigeben möchtest. Ich glaube, da musst du noch mal draufklicken.
Also ihr seht jetzt kein Bild von mir?
Nein.
Auch dich sehen wir.
Dich sehen wir nur.
Okay. Na super. Warte mal.
Schaff mal schon. So while we're waiting, we are going to see Otto live in Copenhagen for the Europerio, right? So whoever's watching.
Better now?
Yes, perfect. Got it.
This is perfect now.
I'm sorry. Good evening to everybody It's definitely my pleasure to participate in this specific format. It's just nice, I think, on a Tuesday evening. And actually, it's true. I want to take you to, let's say, a little bit different idea. And I think to get started into that, most probably there are different reasons, but the most important reason is probably due to the early enthusiasm about the incredible success story of dental implants. It's the reason that for a certain period of time, clinical conceptions that favored implant replacement over tooth preservation with, let's say, terms like strategic extractions or preventive extractions have been very common. As a matter of fact, it's the solid body of research evidence that has led to a consensus within the dental community that such conceptions cannot be justified anymore. Based on meta-analysis, based on systematic literature reviews, we can absolutely say, yes, it's true. Dental implants are a success story, an incredible success story with survival rates over a period of 15 years with more than 90%. But on the other hand, we should never forget that, on the other hand, the survival rates of implants do not exceed the survival rates of compromised teeth, even very severely compromised teeth, on a long-term run. On top of that, and this is maybe in this discussion even more important, is that if we look beyond pure survival rates to success rates, that biological implant-related complications, namely peri-implant diseases, peri-implantitis, are not very rare, with something like 20% over a 10 years period. Most important to mention that whereas periodontitis can be treated very successfully, peri-implantitis till to this day cannot be treated that successfully. And if we fail to treat peri-implantitis, and if for this reason we need to take implants out, have to replace them, retreatment can be enormously challenging, not only for the dentists, it can also be very, very challenging for the patients. And last but not least, it needs to consider in this context that implants, and this is maybe a big disadvantage as well, are ankylosed in the bone. And for this reason, they cannot follow natural jaw growth and tooth migration. And in consequence, we do see very often discrepancies in the tissue height between implant restorations and natural teeth long after patients have finished growth and development. And this plays in particular a very important role in the upper anterior segment, where this can end up not only with severe biological, but also severe aesthetic consequences that sometimes cannot be resolved anymore. So against this background, and also in view, so here's some of the research informations on these issues, and also in view of demographic changes and increasing life expectancy, I think it's very obvious to all of us that the risk for biological long-term complications with implants is as higher as longer implants need to be in patient's mouth, and the risk for biologic long-term complications is as lower as shorter implants need to stay in patient's mouth, and therefore clinical conceptions that favor tooth preservation and postpone implant placement as long as possible makes a lot of sense. I think from the very beginning, this is fact. I mean, this seems to be straightforward. This seems to be very, very clear. However, if it comes to the borderline of tooth preservation, this is sometimes not so clear. This is sometimes very difficult. Sometimes it's hard to assess what a hopeless tooth is. And sometimes it's even more difficult, towards the patients to understand, if a patient would really benefit from an attempt to maintain the tooth, even in particular in situations where patient criteria of success, patient strategic treatment goals can be very different. And here starts the idea of my presentation today, because I would like to present to you, I would say, an up-to-date thinking models, mainly for maybe younger professionals that can support them in the future exactly in this, let's say, borderline decision-making processes, to give them more safety, more confidence in taking these decisions in the future. So what is this concept about? What is the thinking model about? So let me show you the following. What you see here is the circle of life. It's supposed to be the circle of life. So it starts at the lower left and it ends at the lower right. In this life circle, we do see individuals, let's call them patients for that moment, young age, middle age, and high age patients. If we start and focus at young age patients, it's quite clear to all of us, these individuals have their life ahead of them. And in the discussion at the borderline of tooth preservation, we can say in particular, for these young individuals, it's most important that we would not, lose any chance to maintain and save teeth. These individuals mainly lose their teeth due to trauma, and due to trauma mainly in the upper anterior area, which is most critical also for implant replacement, as we all have understood in the meanwhile. It's difficult to say what the right time point would be, what is young in this context, when starts middle age, would it be possible theoretically to place an implant? Nobody can say that today. Let's hypothetically just set a mark there. Let's say up to there, we talk about young patients. So if you have such a young patient, and I want to introduce to one of these patients, so she's a female patient, she's a little bit more than 30 years old. There is a situation with a bike accident with a horizontal root fracture, and important is here that she has a very high smile line. So here's the situation. This is after 1 week after emergency treatment. So a splint has been bonded to the teeth. So the teeth were also quite mobile in this situation. So the occlusal view, and you see the main problem here. So besides crown fractures at the neighboring teeth, it's a horizontal fracture here of the right central incisor. So taking in consideration the age of the patient, taking in consideration also the fact that we are in an area of high aesthetic relevance, a high smile line. So in this particular situation, we decided to maintain the tooth. How could this be accomplished? It's clear this is a quite high effort to do that, a very high effort to do that, but still we decided to maintain the tooth. So here just a few pictures from the treatment sequence. So first of all, endodontic treatment has been done. Of course, a post needs to be positioned. The post in this situation also fixes the fractured crown to the root. That's what you see here, to make sure that we can remove the splint. Otherwise, the whole thing would be mobile. This is what you see here after endodontic treatment. So the post through the crown, through the fragments even that you see in between crown and root, just to stabilize the situation. So to restore the tooth, we took the decision to orthodontically extrude the tooth. To do that, you see here the braces bonded to the teeth. You also see here the anchorage at the palatal side with orthodontic mini implants, just to create a rigid situation for the neighboring teeth, not to cause any intrusions, just to purely be able to extrude the involved tooth. This is a situation here quite early. This is after 4 weeks. The periodontal ligament needs to be cut regularly every 2 weeks. You see here the small fragments have already got lost, they have fallen out. So I just filled the space with composite, closed the space between crown and root. That's what you see here in this picture, in this situation. So this is again after a healing period here of 4 weeks and a retention phase of 3 months. And then we kept on and we just prepped the tooth here. It's a conservative preparation, just to go a little bit under the soft tissue line to change the contour of the tooth, the quite narrow root contour, into the contour of a normal central incisor in this position. So here is the situation with the final restoration, the all ceramic crown. If you look here at the X-ray, you see the enormous extrusion that has been accomplished. So it is something like 3 to 4 millimeter in this situation. So in summary, let's say a very high treatment effort, in this situation. And the reason why this has been done, because it's a patient which is quite young, still quite young. We have a high smile line, and we tried to postpone somehow, if possible, implant placement as long as possible. How long will it last? This is the most important question. The answer is, I don't know. Can such a tooth crack? The answer is yes, such a tooth can crack. That's why you can only take such a decision together with the patient. You have to take the patient by the hand. You cannot take the responsibility alone. But as said, for this type of patients, it makes a lot of sense to postpone implant placement as long as possible. If in other situations such a tooth can not be maintained, if this is not possible to maintain such a tooth, here just another case example. Here we have a similar situation. Also here it's a bicycle accident that you can see. It's also a young patient. Here it's 4 years after the accident, and what you see here is the result of a traumatically induced resorption process. So there's nothing that can be done for the tooth anymore. So if you look at the 3-dimensional X-ray picture, so there was no way to maintain the tooth. So this tooth needed to be extracted. And of course, in such situations, most probably also a high smile line patient, the implant restoration is not a good idea. So if you can maintain, don't place an implant in these situations. Depending on the age of the patient, always think about autotransplantation, always think about orthodontic space closure. The things are very important. Think about resin bonded restorations, which are perfect in many, many situations. And this situation in particular, if it's about a central incisor, where very often we cannot control occlusal load in centric and eccentric, how you can sometimes be very creative. So here, for instance, we did a decoronation. So you see still the root is in the socket as a alveolar ridge preservation procedure. So we decided to fill the space. We also decided to treat the recession that's been there already before. And we anchored a pontic on a palatal implant. This looks maybe a little bit, let's say, strange for many of us, but as you will see in a minute, this had many, many advantages. You might ask yourself, what patient can at the end stand such a restoration? Many patients can stand such a restoration. Will this be forever? Most probably not forever. We will see what's going to happen for this patient in the future. But the idea behind that, and this is the most important thing to understand, nothing has happened so far. This is a very young patient. According to, let's say, mean life expectancy, there are another 60 years to go, and nothing has happened so far. Everything is open for the future. So this is absolutely reversible. The idea is just to postpone implant placement as long as possible. It's also clear, so here, for instance, just a post-op picture, the cleansability of this is important, of course, and for him, it's even more important for the years to come. If we would have a failing tooth, same tooth, but the patient now is at the end of his 60s, of course, the decision-making process would be very different, very different. So it's the same tooth. We have a vertical root fracture And of course, this is definitely a candidate here for an implant restoration. And these patients, of course, can absolutely benefit from the achievements of modern implant dentistry. So many things that can be done for the patients today, quick, effective. So here in this situation, flapless implant, immediate implant placement, immediate restoration of the missing buccal bone plate here with a graft from a tuberosity area, a combined bone connective tissue graft from the tuberosity area. So a very elegant way in these situations. So the customized healing abutment, alveolar ridge preservation as well. As you can see, this is the removable temporary restoration. This is 3 months later. Here, a nice maintenance of the tissue buccal of the implant restoration. And this is the final implant restoration. So it's the same tooth that failed. The difference is the age of the patient, and therefore the treatment protocol is very different if you compare this to the situation before with a young patient. Interesting here is, and I don't want to miss that, what you see now is nothing else but a 3 years follow-up. Look at the incisal edge. This is a 69 years old patient. But you see, even in this type of patients, there's still ongoing tooth migration. There's still ongoing changes in the jaw growth. And you see a small step. The patient would never concern about it, but you see, this is not a matter of age. So this ongoing tooth eruption is a problem for many patients independent of age, and we have to take this in considerations. If we talk about areas of high aesthetic relevance, if this would be a bicuspid in the lower, if this would be a patient with a low smile line, the decision would not be that difficult. We are much quicker at an implant restoration, but not if this is in the upper anteriors and if patients would show. So this was young patients. This was on our life circle, a group of young individuals. So now let's keep on going and now go more to the right side in middle-aged patients. So here the situation is to some extent different because slowly implants come on stage as a reliable treatment option. Also here we will do our very best. This makes a lot of sense, not to miss any chance to maintain even severely compromised teeth. But here things start to become, to some extent, a little bit different. So here we need to discuss with the patient treatment options, different treatment options as we have to save the teeth. This will be done mainly based on evidence-based dentistry principles. But as already said at the very beginning, if it comes to the borderline, this is sometimes even based on evidence-based dentistry, very, very difficult. To judge what a hopeless tooth is today is sometimes very hard. And, to, let's say, get an idea if an attempt to maintain the tooth is for this patient really beneficial is also sometimes very, very difficult, mainly due to the fact that the criteria of success, the treatment goals are also very different from patients to patient. If you are in doubt, very often individualized oral medicine can give important hints in one or the other direction. Most probably in the near future, we will have the possibility to get molecular and genetic risk profiles from patients. For the moment, we can handle this issue only much simpler. So I just can say it like that if you have a patient who has a high risk for caries, he would most probably rather be a candidate for an implant, whereas a patient with a history of periodontitis most probably is the person where you rather go to the limit of tooth preservation, because these are the patients who are also obviously on risk to develop periodontitis. So the individual risk profile can also play a very important role. But most important, even in this decision, is the patient. We have to take the patient in the center, under the heading of personalized oral medicine. This is influenced by evidence-based dentistry. Yes, this is influenced by individualized oral medicine. At the end, also we have to listen to the patients. And as you all know, the willingness of patients, not to give up, to fight for a tooth, if the only alternative is the extraction, can be very, very different from patient to patient. And this also makes understandable that a valid evidence-based decision, in favor of a tooth, pro-tooth, can definitely be taken, even if a tooth is severely compromised, can even also be taken pro-tooth, even if in situations where we might to fail with an attempt to maintain the tooth. I think this is the most important thing. The patient is in the center of such a decision-making process. You will not do anything against the literature. This is not what I want to explain to you, but within the frame of evidence-based medicine, within the frame of evidence-based dentistry, it's the patient that we have to take by the hand and take with the patient together the decision. So let me share with you a few examples to further explain you what I want to say. So here we have now a mid-aged patient. You see it's a lady. She's in the middle of her 60s. There's nothing relevant from a medical point of view, but she has recurrent periodontitis on her first molar at the lower right side. This is the situation. This is the clinical situation. This is the radiographic situation, quite some loss of periodontal attachment. This is the perio chart. And if you now start to come to a decision-making process for this patient to maintain or rather remove such a tooth, I would say we have different levels that we need to discuss. Look, this is what I want to share with you. I think the first and most important thing is the age of the patient. She's in the middle of her 60s, and from what we discussed, before, but definitely understanding that the risk for biological long-term complications with implants is dependent on the age of the patient. This is clear. This is definitely a candidate for an implant restoration. If you now in the literature would compare, let's say, a resective periodontal surgery compared to the single tooth implant restoration, I do think both treatment options have a quite good scientific documentation. Looking at the risk profile with a patient being diseased on periodontitis, he's rather a candidate to maintain the tooth, because patients with a history of periodontitis are also the candidates to develop peri-implantitis in the future. And most important, it's the patient who wants definitely not to miss any treatment option to save the tooth, and therefore the decision is towards tooth retention and against the implant restoration. So how can this be accomplished? This might look very old-fashioned. This is a tunneling procedure. This is absolutely not old-fashioned. This is very hot, at least for me. This is not techniques from the 1970s or 60s. These are techniques that can be taken in the context of modern, let's say, modern dentistry, minimally invasive dentistry. This is not aggressive. This is still something we can do to save teeth. So this is minimal bond reduction, just to open the space for an interdental brush. There's not even touching the interproximal spaces. You will not sacrifice any periodontal tissue. You can maintain the supracrustal fibers. This is fiber retention. This can be minimally invasive done. You don't need to apically position a big flap. It's only locally in between the roots. So the periosteum is an anchor used at the buccal side. As you can see it here, it's the alveolar mucosa at the full thickness flap at the lingual side that you use an anchor. So we can localizedly position the flap in an apical position just to open up the space in between the roots. That's also from the lingual side. So to allow cleansability in this area for this patient. So this is after the healing, this is the interdental brush. So for this person, for this individual, I would say a quite predictable solution in her situation. Let's continue. It's the exactly same tooth in a different type of a patient. Now we have a male patient. He's about the same age. The difference is that he has also a grade 3 furcation, but he is running since years with a high risk of caries. What you can see here all at the pre-op clinical picture. So it's the same tooth, but if you look at the X-ray, if you look at the history of the patient, he's running a high risk for caries. So although the situation is similar, we decided for this patient a little bit different, as you will see in a minute. So here the radiographic finding. So for him, it's the age again, absolutely an implant candidate. Again, the scientific evidence between tooth preservation and implant replacement would be more or less the same. However, the risk profile is very different, isn't it? So since he has a high risk to develop caries, most probably he would be rather an implant candidate looking in the future. And the patient is also going in this direction with all the experience that he had made in the past. So the same tooth, more or less the same clinical findings, but the decision-making process in the opposite direction. And if this is fact, of course, also here, these patients can absolutely benefit from the huge achievements of modern implant dentistry here, also in the molar side, immediate implant placement, implant bed preparation through the root, as you can see that here. So flapless implant insertion, that's what you see here. Immediate impression, so this is done with a scan body today. So digital impression at the same time. So that's what you see with the healing abutment. Post-op, you just let it heal for 8 weeks. That's what you see here. And the final restoration can be fixed to the implant body, as you can see here, one-piece restorations. So if the tooth needs to be removed, of course, patients can benefit from all the achievements of modern implant dentistry. So again, although the clinical situation quite similar, a totally different treatment decision for him. Another example, you see the patients are all about the same age. So here you have again a patient with a history of periodontitis. She has a generalized periodontitis. So we will focus only on one area, as you will see it here. So here, look at the first molar. So a quite, let's say, pronounced periodontal disease, open furcation, as you see here at the periodontal charting. So it's different to what you've seen before. And again, if you look through our chart now, it's the same again. We're looking at the age. Of course, this is a candidate for an implant replacement. Looking at research evidence, you know, if you again, we would compare resective periodontal surgery with root resection compared to the implant, single tooth implant restoration in the area. It's also, I would like, comparable long-term prognosis. The risk profile, everybody understands. With a history of periodontitis, we should not miss any possibility to save such teeth. But also here, most important, the patient wants to maintain the tooth. She doesn't want to, you know, miss any chance, any opportunity to save the tooth. And I think this is the most important issue in this situation. It's the patient, you know, who will not, you know, give up so easy. And so we decided for tooth retention, again, in her specific situation, now at a periodontally involved tooth in the upper molar area. And again, so here is the situation of the removal of the restorations. This is now resective periodontal surgery. Again, this is not old-fashioned. This is still hot. This is not what's been done in the 1960s. This can be absolutely put in a modern context in these situations. Minimal invasive, fiber retention technique, many things can be done. They could not be done in these days. So you see here root separation and resection of the distobuccal root in this situation. This is the healed situation after 4 months. As you can see here, this is the final all-ceramic restoration for this patient in this situation, cleansable, and she has maintained her tooth. This was her biggest wish. Another example, last but not least, also here we talk about upper molars now. It's a patient who is a little bit younger. So here again, we have a caries problems. I know this patient since a long time, and since I know him, we are dealing with caries. And so also here, you see a similar situation. So you see secondary caries on the two crowns, on the two restorations. You see the apical lesions at the apices of the teeth. So a different situation and a different risk profile. So if we go again through our chart, definitely a patient where we could think about an implant restoration. Again, it's the same thing. I think comparing today resective periodontal surgery with single tooth implant replacement, the research evidence is quite similar, but the risk profile, with a high risk of caries, the patient has proven to have a high risk for caries during the last years. He's going over implant, restoration, and the patient values are more or less, he doesn't too much care, because he has made all this bad experience with his teeth. So we decided here for implant replacement. So again, a similar situation, but the decision based on age, based on scientific evidence, based on the risk profile, together with the patient, went towards implant replacement. And also here now, many things can be done, today that could not be done in the past. So also here, this patient can benefit enormously from the achievements of modern implant dentistry. So here now in the upper jaw, similar to what you've seen before in the lower mandible. So implant bed preparation through the root. So this is a big simplification. Once the tooth is extracted, implant preparation is much more difficult to do. So here, sinus elevation in this situation, as you can see that here. So minimal invasive proceeding on both sides. And now the same thing can be done. We can place the implants immediately. Also, the final impression is made immediately, customized healing abutments, as you can see that here. So here we wait longer. This is now 3 months later, the healed situation. This is what you see. The final implant restorations already finished here. So screw retained. This is the X-ray after that. And this is the patient at the end of the treatment. So this was just to make you understand, to let you follow my thinking processes. This is the up-to-date thinking model I wanted to present to you, which explains to you, it's on one side, it's the age, On the other hand, of course, it must be the evidence, it must be the research evidence, but most important here is also today the patient, to put the patient in the center of our decision-making processes. So let's now go down now from middle age to high age in again, a quite different group of patients. As we all know, depending on how old patients are, these are a group of patients which are frequently affected by chronic diseases, by multimorbidity, by care dependency, by frailty, and of course, cognitive restrictions. And of course, for this group of patients, the same things are true. It's the literature, it's the individual risk profile, and of course, it's the patient, him or herself, that plays the most important role. But in this group of patients, another issue becomes enormously important, and this is, of course, the mental and physical stress for these patients to go through the treatment. So this is another thing that plays a more important role if patients become older, and also this will influence our decision-making processes in these situations. So to make sure that we can reduce the treatment effort, the treatment time, the number of surgical interventions to absolutely the minimum possible. But also here, the decision-making processes can be very different. Look, here is now a patient in the beginning of his 70s, he's 73 years old. So he's a periodontitis patient, and you see he is not from general health issues. There are some concerns, as you can see. And, here it starts to become quite difficult. Would it be possible to maintain some of the teeth? Yes, most probably it would be possible. but, to maintain these teeth, over temporarizations, to maintain these teeth, place implants in between, the treatment effort would be enormously high. So taking everything together for this patient, we decided here a little bit differently. So again, go through our chart. So we have now a patient in a higher age. Looking at of course, it would be possible to save some of the teeth and only place selectively implants in between. The risk profile, very clear, would rather tend towards tooth retention, because he's actually a patient with a history of periodontitis. But looking at patients' values, and this is not the personal opinion of these patients, this is mainly related to the fact that we should make everything to reduce mental and physical stress for this patient. And so we decided actually to remove the teeth in the upper jaw and place implants. That's what you see here now. So temporarization on four teeth that were maintained temporarily. 4 straight implants. I think this becomes now important to have a situation which is cleansable for these patients, which is probable for this perforation. So it's a removable appliance that you see here. Don't underestimate, if patients are becoming older, if patients are really old, we don't see them anymore, but never forget that in many of these situations, it's not the patient who needs to clean, it's nursing staff who have to clean the implants, who have to clean the restorations. And in such situations, this is definitely possible. This is easy to clean. This is easy to maintain. So for this group of patients, this also plays a very important role in the decision-making processes. So here the final restoration, here just a few pictures from the inside, and also cleaning the restoration, easy to clean, easy to maintain for such a patient. The last patient that I would like to share with you is again a patient in the older age group. So she's in the middle of her 60s now, and also her teeth are not in a very good situation, as you will see it here. So this is also a periodontitis patient. You can already imagine from the flaring of the teeth, you can imagine from the amount of destruction that you can see here. This is the occlusal view in the upper. This is the occlusal view in the lower. So also here we have severe periodontal disease all over. But, again, look at the periodontal charting. So open class 3 furcation, so deep probing. So similar, although the patient before had not that many teeth anymore, but at the end, let's say the periodontal destruction quite similar. Also, if you look here at the X-ray picture, so here also left and right, upper and lower. So severe periodontal destruction, also severely compromised situation for her. But still, the decision-making process was totally different. Of course, she's also in an age, there's no discussion. Of course, she can be restored with implants with a low risk for biological long-term complications in her. Scientific evidence in one or the other direction is probably not that difficult. If you look at the risk profile with a history of periodontitis, of course, she is on the tooth side, so we have to be careful. But here, the most important thing, again, is she wants to fight for her teeth. She doesn't want to give up. She doesn't want, she has taken the decision to take care of her teeth now, and she wants to do everything to maintain her teeth. So totally different to the straightforward treatment plan that we have seen before in a similar patient with the implant restoration. In this patient, we decided to maintain all the teeth that could be maintained. A quite high treatment effort, a very high treatment effort, but it was the wish of the patient not to let anything untried to maintain her teeth. So many things have been done. So we could not maintain the posterior teeth in the upper maxilla. We could maintain the teeth in the lower. We could maintain the upper anterior teeth. That's what you see here. Some periodontal treatment that's been done here. This is at the time of re-evaluation. You see the posterior teeth extracted in the upper, but a quite good situation that we could achieve here for the rest of the teeth. So we could reduce probing depth. It's a healthy good situation. So now we planned orthodontic therapy, to bring the teeth back in position. What you see here is a diagnostic setup. So here virtually, the situation after orthodontic therapy was visualized here. So the implants were already inserted in the final tooth position. That's what you see here. So just a few pictures. This is after finalized periodontal therapy, a totally healthy periodontal situation, good, let's say, good oral hygiene of the patients, good compliance. So as discussed, the implants inserted in the virtual prescribed situation. See here, this looks a little bit strange, but this is only because the upper anterior teeth are not yet in the decision that they will have after orthodontic therapy. So now you see here temporaries to open the bite, the vertical dimensions on the implants, which are also used as anchors for the orthodontic treatment of the teeth. So that's what you see here. Slowly close the spaces for this patient. This is at the end of the treatment. So to get a better aesthetic outcome for these patients, the open embrasures were closed as much as necessary for her smile line with composite in between the teeth to give you some more aesthetic at the end. So here is the situation after finalized orthodontic therapy and the restoration of the upper anteriors. This is the lower situation. This is now the final ceramic work. In these patients, enormously important, cleansable, probable. This is the most important thing. This is the contralateral side. So a healthy clinical situation, upper and lower. This is the periodontal chart here. This is now 3 years follow-up that you can see for this patient. So the point I want to make, it's finally the patient. Whereas in the first patient with, let's say, I would say a similar situation, we decided for the good of the patient, to go in restoration. For this patient, we decided to go in the opposite direction with a high treatment effort, but this was for the oral health related quality of life for this patient very important. And that's why the decision-making process was very different. So this is it. This is the thinking model that I wanted to share with you. And I think the most important thing, the most important message is we should do everything to maintain teeth as long as possible and postpone implant placement as long as possible. Age matters, of course, the longer implant needs to stay in patient's mouth, the higher is the risk, for long-term complications, biological long-term complication. And if it comes to the upper anterior, another aspect play a very important role, which also will influence our decision-making processes. Most important, and I think this is also an important message, today it's definitely not to be for or against implants, to be for or against teeth. Much more, the message is to merge tooth preservation and tooth replacement, to merge them both for the good of the patients in a very meaningful way. Chris, how will we proceed? We
will go on. First of all, wait 1 second. Christian has to get us back on the screen. Yeah, thank you, Christian. Otto, I thank you before we go on, because I think this is a lecture which is so important for everybody, because on the stage you always see big scientific discussions about implants and how they work and how much bone you can build up. But you've shown, and I've seen this some cases of this in Frankfurt, which really impressed me, because there are different ways than implants to help the people. And I think sometimes we forgot that there are many ways to preserve teeth. I think sometimes it was very difficult and it's a long time for the patient, but I think the outcome of all these cases is great. But I worked in your office, so I know how your recall system works, but I think it's extremely important to mention that all these cases with and without implants can only work if everybody has a good recall system in his office. Yeah, I think if you have implants, you need a recall. If you don't have implants, but the severe case of periodontitis, you will also have failures if you don't place implants. But perhaps you have some words for this, because I think this is so important.
Look, I think in the decision-making process between teeth and implants, listen, and not to forget, I was talking really about the borderline situations, where you're not sure anymore if it's really, makes sense to make an attempt to maintain a tooth. In all the other situations, I would not even want to discuss this. This is very clear today that we should maintain as much as possible. Right? At the borderline, this is sometimes really very difficult, very difficult, And the importance of maintenance care is independent of that. It is independent of the decision for or against a tooth or for or against an implant. We are discussing risk patients anyway. These are patients who have a risk for caries. That's why they end up the way they ended up. And these have a high risk maybe for periodontitis. And with teeth or implants, these patients need maintenance care. So that's why I think this is the key for everything in this type of patients. But this is not really influencing the decision-making process, because this is true for both teeth and implants.
Yeah. Perhaps when I have a problem with my camera, I'm back in 1 second. There's a question of Roger. He says, thank you for the amazing cases. The key message you want to give tonight to fight to preserve the tooth by an expert in perio and implants is based on the unpredictable prognosis of tating peri-implantitis. Thinking on the long run, this was the question. What do you think about this?
I have not really understood the question. What is the what?
Well, it's a comment more than a question. The key message you want to give tonight is to fight to preserve a tooth, either by an expert in perio or in implants, is based on the unpredictable prognosis of treating peri-implantitis, which is taking the long term into consideration. Sorry, Chris.
I think we have to, the thing is, we have a patient who has a certain age. Let's say the first cases that I showed you are young patients. And no, I'm in the meanwhile quite some years in the field. And, if a patient, let's say the patient is 30 years old, you extract a central incisor because the tooth cannot be maintained with no means, and you place an implant. And the outcome is just beautiful. You publish it, you show it on stage, it's just beautiful. But what I have learned in these patients, that treatment success cannot be just 1 year later, because this patient has another 60 years to go. And 20 years later, things look sometimes very different in these patients. If there is ongoing tooth eruption, if there's ongoing growth of the jaws, this sometimes ends up with situations that cannot be resolved anymore. These are aesthetic, let's say, failures, which cannot be treated anymore, because it's really very difficult. So this is what we have to have in mind. This is one thing. This was the first type of patients that I wanted to share with you. If patients are getting older, if, let's say, we are talking about teeth which are not in the middle of the face, it's definitely right what you say. It's the risk for peri-implantitis, which is there. You can always say it's only 20% over 10 years, but I would say this is quite a lot. And, if we fail to treat peri-implantitis and implants need to be removed, retreatment can be, very difficult. This can be big surgery, this can be bone reconstruction, no matter what it is. So it's quite clear to me, the longer we wait, the longer we can maintain tooth, the later the implant comes on stage, I think the better it is for the patient. Taking the life circle of patients, not taking the moment, looking in the future, I think this is a very important thing that we need to discuss. Don't take the decision easy to extract a tooth. There are many more years to go.
Otto, there's the question coming from Peru, from Lima. And Sixto Garcia is asking, will you think that the perio phenotype is the key to evaluate in the latter of cases? I think when you talk about aesthetics and the eruptions, I think, do you think that the phenotype, when you have a thick one or a thin one, that this makes a difference in your decision?
First of all, I don't know. And I don't know, and it does not make a difference in my decision making. So if you go in the literature, if you go in the literature to look on tooth migration over years, you will see different things. The first thing is that this is more or less independent of age. This is not that tooth eruption stops at the age of 30. It can also happen, as you have seen in my case example, in the age of 45 and also in the age of 55. This is message number one. Message number two, it doesn't happen in all of the patients, So who is then the candidate for further tooth migration? There are some, let's say, some ideas about the growth pattern, so that this might play a role. I have never heard about ideas of the gingival phenotype, if this would play a role. So honestly, as long as I do not know who the patient is who will experience further tooth migration, I'm just very conservative with implants. If patients do show, don't get me wrong, if patients don't show, if this is in an area without aesthetic relevance, if this is the patient with a long beard, you know what I mean? If there would something happen in the future, you might change the crown, if there was an incisal step. This is not so bad. But if patients do show, if they have a high smile line, at the moment, this does not influence my decision-making process. I'm just very conservative with implants.
Okay. And there's another question. Do you think that the replantation apply on periodontal cases would be an option for you?
Replantation?
Yep.
So replantation would mean you take the tooth out, you clean the tooth and replant it?
I don't know, but what for this question, I don't know this, but for example, I saw cases where people take out teeth, replant them in the anterior zone, and after that they prep it to place veneers or crowns to have a new tooth there. Do you think this is a good option for you? Or would you ever go?
This is something you always have to consider. Look, this is a topic for itself. So also here, the age plays a very important role. So if you have an 11-year-old girl having a trauma, having an accident, whatever it is, so the central incisor cannot be maintained, definitely. Autotransplantation, for instance, just say it, you have a second premolar in the lower mandible with not fully developed root. This is the direction to go. It's a very safe procedure. So the chance that this tooth in the position of a central incisor will survive for a lifetime is very, very high. So if the same tooth, needs to be extracted in the age of 30 or 40 or 50, it's a different story. Still, you can go ahead, you can extract a tooth, let's say a wisdom tooth, which is still impacted. You have to do endo treatment then because the root will be developed, and you position a small wisdom tooth, for instance, upper wisdom tooth, in the position of a central incisor. This can also be an option, but let's say the prognosis is decreased. So the risk for root resorption is just there. So it depends a little bit. You always have to think about autotransplantation if this was the idea. Not replantation, but autotransplantation. This is always an idea. And for young patients, is most probably the golden way to do that. For older patients, you always have to think what's happening at the area where you extract the tooth. How can we deal with this area? This is one thing. And the other thing is, of course, there's also risk to end up with resorption, but it's always an option, and it's a good option.
Okay. The case where you showed the ortho after the perio regeneration, there was the question, how long do you have to wait after your perio regeneration till you start your ortho treatment?
So there also are different opinions out. Honestly, in this patient, I was waiting for 6 months. This is more like a gut feeling, because these teeth, as you have seen, have not that much left periodontal attachment. So I waited longer for more stability, and the movement itself was very, very, very slow. In other situations where you would have more periodontal attachment, you might already start after 3 months.
Yeah, okay. Let's see, do we have another question? Thank you so much for the, what? Excuse me?
One more, and one comment and one question.
Yeah, okay. Thank you so much for this excellent presentation. Doctor, in the last case, you decided preserved teeth. You just put BMP, Emdogain, just in one sector. For what purpose do you put this just on this sector? I think this was just because you made the photo on this sector.
No, it's just, this was a big case, and I just selected one photo for what we did in periodontal surgery. Many more things have happened, but I just put this one photo. This should not be misleading. It was just one photo, but this happened on more teeth in the upper and in the lower as well.
Okay. So Christian, I think we answered all the questions.
Yes. Only Sixto Garcia would like to thank you again for a lecture that you held in Lima in 2016. He forgot to say that. That was a comment.
Good. Yeah.
Yes.
Okay. Otto, we are perfectly in time. This was 1 hour of the Quintessential Tuesday, and it was a very interesting lecture. A lecture we have to think about concepts in our offices, and I really like to thank you. And Christian, where do we see next
Well, Otto, we will see each other most likely at the Europeria in Copenhagen, where a lot of people usually go. I don't know, Otto, you are also going to be in Boston, and I think Chris also, right?
Yes.
Yeah, I will not be there.
You will not be there. Well,
I have to work on the book.
Yes, that's correct. So if you want to join us in Boston for the ISPRD meeting, Dr. Chris will give a workshop with his wife. Unfortunately, Otto will not be there, but Otto is live on stage in Copenhagen, right?
Yes.
Yes, and at the EAD maybe also. I'm not sure, Otto, are you going to be at the EAD? Also no.
No, he has to work on the book.
Busy man, absolutely, yes. Okay, perfect.
So let's end up this evening. Perhaps, Christian, we raise our glass again.
Yeah.
Because for us, it's over now. We can go home to our kids, to our family, everybody else in the world who has to go to his office. I wish you a nice day, Otto. Thank you for this evening.
Thank you very much. Thank you very much.
Thank you, Otto. Thank you, Chris. Thank you, everybody, for watching, and see you soon.
Bye-bye. Thank you very much.
Thank you.
Bye-bye.